Good morning, Professor.
Good morning, Sir Brian.
Now, let me explain what the arrangement is. You're talking to a select group here in this room in Aldwych House in London. I'm saying that because there are about another 100 or so people who will be watching online from different parts of each of the four nations in the UK. So, to your left, there are lawyers. The public are in front of you. And in a moment or two, Mary will ask you to take the oath. We will have breaks. The first break will be around about 11:15 at a convenient moment. During breaks, you must not talk to anyone about the evidence you have given, because you're under oath, nor about any evidence which you think you may yet be asked to give, but you can talk about anything else you like. Mary.
Please state your full name.
James Wilson Ironside.
And repeat after me. I do solemnly, sincerely,
I do solemnly, sincerely,
and truly declare and affirm
and truly declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Professor, I'm going to start by going through your qualifications and an outline of your CV. So you obtained a BMSc at the University of Dundee in 1976, is that right?
Yes, that's correct.
And then you obtained an MBCHB, again from the University of Dundee in 1979, an MRC Path in Neuropathology in 1987, and an FRC Path in Neuropathology in 1997.
Yes.
The first role you undertook it was as a medical house officer in 1979 at the Nine Wells Hospital in Dundee.
Yes.
And you then became, for a short period of time, a surgical house officer at the Strathcrow Hospital in Brechin, sorry for my pronunciation, and then moved in 1980 to, as a senior house officer in pathology back at the Nine Wells Hospital in Dundee.
Yes.
You were then became a registrar in pathology again at the Nine Wells Hospital in 1981, taking up a post in 1983 as a senior registrar in neuropathology at the Royal Hallamshire Hospital in Sheffield, as well as undertaking a role as an honorary tutor in pathology at the University of Sheffield.
Yes.
In 1986, you became a lecturer in pathology at the University of Leeds and were also undertaking a role as an honorary senior registrar in neuropathology at the Great Infirmary at Leeds.
Yes.
And then in 1987, you became a senior lecturer in pathology, again at the University of Leeds, and at this time were undertaking a role as an honorary consultant neuropathologist, again at the General Infirmary at Leeds.
Yes.
In 1990, you moved back to Scotland to take up a role as a consultant neuropathologist at the Western General Hospital in Edinburgh, as well as being a part-time senior lecturer in pathology at the University of Edinburgh.
Yes.
In 1994, you became a senior lecturer in pathology at the University of Edinburgh while still undertaking your role as an honorary consultant neuropathologist at the Western General Hospital. In 1998, you became a reader in pathology at the University of Edinburgh, as well as undertaking your role as an honorary consultant neuropathologist.
Yes.
And in 2000, you became a professor of clinical neuropathology, again at the University of Edinburgh, while still undertaking your role as an honorary consultant neuropathologist.
Yes.
And then you retired in 2017, and currently you hold the title of Emeritus Professor of Clinical Neuropathology at the University of Edinburgh.
That's correct.
And is it right to understand that you are still publishing papers despite having retired? despite having retired.
Yes, I suppose old habits die hard, but there was quite a lot of data and work that hadn't been quite completed, so that's ongoing, but it will not last forever.
And we'll certainly look at one of the papers that you've published since your retirement later on today. Your witness statement also sets out at pages 3 up to page 5 a number of working groups and committees and so on you've sat on. I'm not going to run through those. People can look at those if they wish to. But it's right, is it, that you sat on a large number of these working groups, committees and so on, covering a number of important issues such as handling of tissue from patients with prion disease, autopsy practice, advising on reference materials for the assessment of novel diagnostic tests, providing expertise on human prion disease in relation to research funding and planning, and so on.
Yes, that's right.
You also were a member of the CJD incident panel, and we'll come and look at some of the work that you did in that role later on today. And it's right as well, is it, that you were at some point the deputy chair of that organisation?
I don't think I was deputy chair of the CJD incidents panel. I was deputy chair of SEAC, I think, for a short
Sorry,
period.
yes, I can't read my own notes. That's exactly what it says. You also sat on SEAC and you were deputy chair
Yes.
of that organisation. Thank you. Can we turn to DHSC 306601_009. This is a meeting minute note of the Advisory Committee on Dangerous Pathogens, often referred to as ACDP, Spongiform Encephalopathy Advisory Committee, joint working group. And we can see that you attended that meeting in July 2001. And I just wanted to ask you about something that's set out at page 10, please, of that the meeting minute notes there, and then ask you a question about the interrelationship between all the different groups. So we can see there that the chairman and the chairs of SEAC and the CJD incidents panel had met with the DCMO, the Deputy Chief Medical Officer, and other senior DH officials on the 12th of June to discuss issues of coordination and interaction between the various BCE and CJD advisory committees and working groups.
Yes, excuse me, I'm sorry, I can't see the document on my screen.
I beg your pardon.
Well, just take
pause
a
for a moment.
We'll get that sorted. Can you manage the questions without?
Yes.
We wait for it.
No, I think probably I'll do my best.
If I read through this passage slowly, it's quite a long passage.
Well, it's the questions that arise out of it, really, that
Yes.
you need to have answered.
They're quite general questions.
Yes.
Well, it's one very general question. The chairman reported that the meeting had been very helpful in highlighting...
I think just one moment, because otherwise it'll be a bit of distraction.
The indication was that I should just wait a short period of time. Perhaps it would be better to wait.
Well, it's up to you. You know questions you have planned. And whatever is easiest for Professor Ironside and yourself, you may want to go ahead with asking the general question if you can.
Yes.
So what we see, perhaps if I just précis what's set out here, what we see is that there had been a meeting, presumably because areas of concern about the relationship between the various groups and fragmentation of debate was a concern, and that it was felt important to clarify the roles of the group and distinguish between the different roles of SEAC, for example, and the roles of the Joint Working Group and the CJD Incident Panel in advising the Department of Health. And the question for you really is whether or not you had any concerns about that issue, and what your impressions were or are about the fact that there were so many different groups dealing with and advising on prion disease and VCJD.
Yes, well, I did share these concerns, and I was involved in the three groups that you mentioned, and it appeared to me that the risk assessment role of SEAC had also spilled, as it were, into also areas of risk management and implementation, and that really was the role of the ACDP, and then the CJD incidents panel dealing with specific incidents that they'd been alerted to, and it was difficult. And I actually, for a while, considered whether I could or should continue in SEAC because of these issues, and fortunately these issues were resolved. I felt able to continue on that basis, but yes, there were difficulties.
So sitting on SEAC, you were, as it were, putting on your risk assessment hat, and then sitting on the CJD IP, you were then putting on your risk management and risk implementation hat.
Yes, yes.
I was going to take you to the terms of reference for SEAC as they were amended in 2004. We looked at with Professor Collins at the terms of reference prior to 2004. But it's quite a long document, and I think it's going to be difficult to do it if you don't have the...
There's nothing there, I'm afraid.
I can just read it out for the transcript, and then others can look at that if they wish to. The reference which sets out the revised terms of reference are DHSC 0041216_035, and it's at page 5 of that document. Just looking at the rather bigger picture, do you recall the terms of reference being amended in and around 2004?
Yes, I do.
And was that as a result of those concerns that you've just been telling us about?
I think it was partly as a result of these concerns, but also in 2002, SEAC had its 5-yearly review, which is a normal process for a non-departmental advisory body. So the previous one was in 1997. This was in 1992. So SEAC was being reviewed anyway, but I think that the issues that we've just discussed then became contemporary, as it were, with the review, and that no doubt contributed, I think, to the revised, amended terms of reference.
As I say, we'll come back and look at some of the work certainly you did on the CJD instance panel later on today, but I just want first to get an understanding of the work that you were doing on the NCJD RSU,
yes.
the National Creutzfeldt-Jakob Disease Research and Surveillance Unit based in Edinburgh. And then I want to ask you some general questions about VCJD. So, having gone through your CV at the beginning this morning, is it right to understand that while you were a consultant neuropathologist at the University of Edinburgh and an honorary consultant neuropathologist in the NHS Lothian Hospitals Division, a post you took up in 1990, you were also undertaking work at the Research and Surveillance Unit?
Yes, that's correct. The unit was established in May 1990 under the directorship of my clinical colleague, Professor Robert Will. And when I arrived in Edinburgh, I'd already had some experience of human prion diseases whilst I was in Leeds. In fact, we identified one of the largest families that were unfortunately affected by one of the inherited forms of prion disease while I was there. And my colleague, Professor Jean Bell, who's also a neuropathologist, was involved with Professor Will in obtaining funding for this, so I began working alongside them, and that's really when I began to get seriously involved in the work of the unit.
And what do you understand to have been the driver to have set up the surveillance unit in May 1990?
As I understand it, it was the report of a committee, the Southwood Committee, I think it was, in looking at the impact of BSE, and a working group set up to look at the potential impact of BSE, and it recommended that surveillance of CJD in the UK should be reinstated. There had been an earlier surveillance project in an earlier decade in which my colleague Dr. Will had worked on in Oxford, so that's where his experience came from. So Professor Will and Professor Bell obtained funding for this, and the idea was to identify all cases of human prion disease in the UK, monitor them, look at the epidemiology, the clinical and pathological characteristics to see if any changes were occurring that might be attributable to the effect of BSE in the UK population.
And presumably you were looking primarily at cases in the UK, were you?
Yes.
But also comparing those cases to cases that were being seen elsewhere?
Yes, that's correct. Similar surveillance projects using comparable methodology were shortly established afterwards in other European countries, in particular France, Germany, Italy, with large comparable populations to the UK. And the number of participant nations increased, and this allowed these international comparisons that you just mentioned. Also, we had the historical data from the earlier surveillance work that had been done in the Oxford project to compare probably a pre-BSE era with the 1990s and then the 2000s.
And so the surveillance work is looking at the different characteristics and whether there are any changes in the form of CJD, as well as looking at trends in incidence rates and prevalence. Is that right?
Yes, that's correct. And the work of the unit also, obviously surveillance is one of the absolutely key parts of the work of the unit, but also research into developing new methods to aid both clinical and pathological diagnosis of CJD, and to undertake research to make the diagnostic process more straightforward and also more informative.
And how did the unit know about cases? Were they referred to you? Did you have to go out and try and find them? What was the process?
We relied on the large network of expertise in the UK. So my colleague, Professor Will, used the Association of British Neurologists, which includes all the neurologists in the UK, informing them of the project and asking them to notify the unit of any patient they thought might have CJD or any unusual form of dementia. Similarly, I and Professor Bell went through our colleagues in the British Neuropathological Society, and so we established these networks of neurology and neuropathology to refer suspected cases, or really any unusual case that they weren't sure about. And that's really how it worked. There were also contacts made with other relevant groups of physicians, for example, clinicians working in the medical care of the elderly and psychiatrists who might come across patients with CJD.
And how effective do you think that system of referral from clinical colleagues was?
Well, I think it was effective. Of course, we can't say it was 100% effective because that's almost, I think, impossible to achieve, but there was a strong motivation from the global community to support the project because everyone recognized the potential significance of it. And that support allowed us to identify variant CJD at a really very early stage.
In some of the documentation, there's reference to you reviewing death certificates. How did that come about?
Yes, that was another way. It was really a sort of, the term backstop is not a very popular one these days, but it was a sort of backstop of looking at death certificates to see if anyone may have died with the type of illness that could be confused with CJD, or indeed had been labelled CJD and we hadn't been notified about it.
We heard from Professor Collins last week, and he told us that the Research and Surveillance Unit was one of the 2 national centres in the UK, along with the prior unit
Yes.
that he ran in London. So is it right that patients were also referred to you for diagnostic reasons, to be diagnosed?
Yes, that's right, and that's why we're interested in developing new methodologies to enable diagnosis. So, for example, one of the services offered is the analysis of cerebrospinal fluid, or CSF, which is the fluid around the brain and the spinal cord. And in CJD, this contains a number of proteins that are not normally present and do not occur in other forms of dementia, such as Alzheimer's disease. So we have a national referral service where CSF samples can be sent in from neurologists or other physicians, and we will do the analysis, and if that analysis indicates to us that this is a likely or is in fact a case of CJD, then we will notify the neurologist concerned, and they will complete part of what is now a national referral system, where it involves completing a notification form and distributing that.
So is it the case that you were working to support neuropathologists or neurologists with their patients rather than directly seeing the patients yourselves at the unit?
Well, it was both, actually. I mean, the patients are seen by research fellows in our who are neurologists or training neurologists. They try and visit every patient. They make an assessment, and they ask the relatives for consent to take part in the case control study. So we're interested in trying to identify risk factors for human prion diseases, including diet, medical history, surgical history, occupational history, a wide range of things. And we undertook that epidemiological work with control cases for patients in the same hospital who didn't have CJD, and also patients who lived in similar geographic areas. And for that we approached the trusts and the local GPs, and that was really a very large piece of work that involved numerous ethics applications to get that off the ground. We also run the national care package for CJD, and we have teams of nurses who are specially trained in the unit who go and visit the patients once they've been diagnosed, to make sure the family receives the support that it needs in terms of the care package.
And is it right that is that nurse called a national care coordinator? Is
Yes,
that right?
that's right.
And they are able to attend regular case conferences,
yes,
and facilitate meetings with other disciplines that might be useful in the care and treatment of somebody with
Yes,
CJD.
that's my understanding. I have to say that arm of the work is not an area of my direct involvement, but I understand that's how it functions.
And did the unit, when you were there, see patients that had been notified that they were at risk of a VCJD for public health purposes?
I don't. I wasn't, as a pathologist, I'm not involved in the clinical referrals. I'm not sure, to be honest. I think that unless the patient develops symptoms that indicate that they might have CJD, then I don't think that would trigger a visit. We did sometimes get, and I do remember, at least on one occasion, receiving a call from an individual who was at increased risk of CJD through treatment with human growth hormone and was concerned that he was developing symptoms, and I then passed his details on to Professor Will, and then that then did trigger a visit because the patient did have symptoms of the disease.
And so that was an example of a patient effectively self-referring to the unit, and that was an acceptable way for a referral to be made?
It was an unusual way, yes. As most would be referred from a clinician, but this particular case, it happens. So it happens through a number of routes, but the commonest route would be through a clinician or a GP.
We also heard from Dr. Hewitt that one of the aspects of the Research and Surveillance Unit's role was its involvement in the TMER, the Transfusion Medicine Epidemiology Review.
Yes.
And she told us, and I don't want to repeat the evidence. Well, just summarize. I'm going to summarise what she told us to see whether this accords with your recollection of the unit's role. That the unit passed on. So you passed on names of those diagnosed with VCJD to the blood services, so that their donation history could be investigated. That was one element of it.
Yes, that's correct.
And a second element of it was that you were informed by the blood services of the recipients of any donations from donors who had been diagnosed with VCJD, so that you could undertake what's called passive surveillance. Is that correct?
Yes, that's correct.
And what is passive surveillance?
Well, passive surveillance, as I understand it, is awareness of those individuals, and then, as I said, not actively becoming involved until they develop symptoms that might then be attributed to it. My role in the TMER study, and again, I wasn't involved directly with Dr. Hewitt and the other team, was to provide a diagnosis of, so if one of the patients under active surveillance had died, the question would then arise, did they have variant CJD or not, and I would try to be able to help with that.
So passive surveillance is effectively sort of checking their name against your database, see whether or not you already know about them,
Yes.
And then checking periodically to see whether or not they are somebody that has been reported to you as actively diagnosed with CJD.
Yes, that's right. I think probably it would also involve checking death certificates to see if any death within that group had been recorded for whatever reason.
And that a similar process was invoked, Dr. Hewitt also told us a similar process was invoked in the reverse TMER.
Yes, that's correct.
Yeah. And I think you told us, I think, in your statement that aspect of the surveillance unit's work was led by Professor Well, isn't it?
Yes, that's correct.
So I'm going to move on now to ask you some questions about VCJD. We heard some evidence about this from Professor Collinge last week, who gave us an explanation as to what a prion disease was.
Yes.
And he outlined briefly the different kinds of CJD, sporadic or classical, acquired, including iatrogenic and VCJD, and familial or inherited. Yes. And he explained to us the difference between primary transmission of VCJD through the oral route, through
Yes.
eating infected, BSE infected meat products, and the secondary route, infection via blood or surgical instrument.
Yes.
And he also told us that patients undergo an asymptomatic phase when they have VCJD, where the abnormal prions or the disease prions are spreading through the lymphoreticular system
Yes.
before they have invaded the brain.
Yes.
So just picking up on that point there, will every person with asymptomatic infection go on to develop symptoms, or is there a carrier state for VCJD?
I think that the honest answer to that is we don't know. The incubation period in these diseases can be very lengthy, and we know of this from studies of the acquired forms of CJD that, for example, in the patients who received the contaminated growth hormone treatment, that was stopped in 1985 in the UK, but we're still seeing small numbers of deaths every year almost since then. So that's 35, heading towards 40 years afterwards. And the evidence we have is that the infectivity can be present in these tissues for perhaps many years. Whether we're in a position to say now that BSE infections, the primary infection has, or the primary exposure, shall we say, has stopped, that BSE is no longer in the food chain, how long will we have to wait to see how many more cases might arise? And the answer may be several decades still.
So do we know whether or not for some people they won't develop it won't develop into symptomatic VCJD?
I think that's a possibility, but it's really very difficult to state that with any certainty. The animal models that have been used to try and understand this situation seem to indicate that that might occur, although the trouble with the animal models, particularly mice, they have a very much shorter life expectancy, and they will sometimes die of other causes before they might go on to, they may have gone on to develop the symptoms.
And so does it follow then, if we don't know whether that's even a possibility that somebody may have a carrier state, that we wouldn't know why that might be?
Yeah, well, if they had, the term carrier state is not one that I tend to use. I tend to call it an asymptomatic infection. So they have been infected with the agent causing variant CJD, probably through the oral route. The infectivity replicates outside the nervous system, as you've just said, and that process can take a long time, and it might depend on a whole number of factors, including perhaps the age of the individual, that exposure, and also individual differences in susceptibility, which are governed largely by genetic differences.
I'll come on to ask you about that in a moment.
Yes.
So you mentioned the incubation period between asymptomatic and symptomatic infection. Is it right to understand it in this way, that where the species barrier must be crossed, in other words, where you've got a primary VCJD infection via the oral route,
Yes.
that the incubation period is longer than where you have a secondary infection, so a route between the same species, i.e. through surgical instruments or through blood and blood products?
Yes, that's correct. It's difficult to measure the primary incubation period in variant CJD, but this has been done both in this country and in France, and I think it was agreed it probably around 13 years would be a likely average. And it's interesting then to look at the incubation periods in those individuals who unfortunately received non-leukodepleted blood transfusions from donors who had developed variant CJD, and the incubation period in these 3 individuals has been shorter, usually between about 6 to 8 years or so.
Is it also right to understand from your witness statement and from some of the papers that have been published that another factor that may affect the incubation period between asymptomatic and symptomatic infection is the genotype of the person infected with VCJD?
Yes, that's correct. All of us have a gene called the prion protein gene, and this makes the normal form of the prion protein, which is present in many tissues in the body, but particularly in the brain. And in this gene, there is a variable region at position 129 called codon 129, and the analogy I tend to use is it's a bit like the genes that determine blood groups. So you can be group A, group AB, group O. And so in prion diseases, the analogy to that is at position 129, you can be either methionine, which is M, or valine V. So you can be MM, MV, or VV. And most of the patients, in fact all but one of the definite or probable cases of variant CJD have been in the MM group. One patient with variant CJD, in fact, the last patient to be diagnosed with variant CJD belonged to the MV group, and we have evidence from our study of a recipient of contaminated blood from a VCJD patient who died with no evidence of symptoms of variant CJD, but did in fact have the infection in the spleen and other lymphoid tissues, and that patient also was an MV individual. So probably all 3 genotypes are susceptible to infection, but the incubation periods will be different, and probably, to put it simply and crudely with a lot of health warnings, if you like, around it, the MM will be the shortest, MV probably somewhere in the middle, and VV the longest.
And is it right to understand that to date, all of the cases of VCJD have been MM, save for one, which has been MV, which was the most recent one?
Yes, that's correct.
So the fact that all the cases to date have been MM tells us something about the incubation period, which you've just outlined.
Yes.
Does it tell us anything else about the genotype? Does it tell us perhaps that those with MM genotype are more susceptible to VCJD, or is it too early to tell that?
I think it's too early to tell that. My understanding from the situation with BSE is that the cattle prion protein at the equivalent position, I think, is methionine, so it's a sort of better match in terms of converting the human protein to the abnormal form, and so probably there's an element of susceptibility as well as incubation period, but it is difficult to disentangle these 2 factors.
And could it be the case that the tests and the diagnostic tools that we currently have are only picking up the MM cases, and that there are, in fact, MV and VV cases that is not being picked up or being mistaken for Alzheimer's or something else?
I suppose that's a possibility. The MV patient that was the one we know who had variant CJD was diagnosed on neuropathological and biochemical grounds. I think there was some debate about whether the clinical features were more similar to sporadic rather than variant CJD, but nevertheless, it was identified as a prion disease to start off with. The others we just don't know. There has been always a concern in surveillance that because of the very large numbers of patients with other neurological disorders in the older age groups, particularly diseases like Alzheimer's disease and other forms of dementia, that someone with CJD may be diagnosed as an atypical form of Alzheimer's disease, perhaps, and that may well be the case. One elderly patient with variant CJD that was referred to the unit was not referred during life as a suspect case of variant CJD, and the diagnosis was only made at autopsy. So we cannot say with certainty that this doesn't occur or will never occur. It probably has occurred, and it's very difficult to estimate the magnitude of that. There is a research study going on in the unit with Lothian Health Board looking at dementia in the elderly to see if there are any cases of CJD or variant CJD being missed in that population. I think that study's ongoing, and I'm not aware of the interim results so far.
And I will be asking you about the issue you've just raised, the case of the VCJD patient who at first was thought to be a sporadic CJD patient, and later on today. So I would like Professor Ironside to look at a document now. I'm told that we're going to need a break of about 15 or 20 minutes in order to sort the screen out. It's rather early for a morning break, but I wonder whether we could take a short break now.
Yes, well, we'll do that. We'll keep it at 20 minutes, I think, and so we'll take a break until actually 11. But before we do, can I just ask you one question? Yes. It's really about labelling. The M, does that stand for methylionine?
It's methionine.
Methionine. Thank you.
Yes.
And the V for valine?
Valine, yes.
Methionine and valine.
Yes.
Thank you.
Yes.
11:05.